Thank you for this opportunity. This is going to be a jarring change, I have a feeling, so hopefully I can make it interesting. So we're going to switch gears and talk about the biology of HIV and what we're doing currently to try and use the tools of biology to stop the spread of HIV. The first issue is to get our head straight about the transmission event. When everything else has failed in structural intervention and behavioral intervention, and the transmission event is going to take place, this is what it looks like. There are thousands of different variants of HIV in the genital tract of an infected person, and then the genital secretions they lead to exposure to the mucosa of the uninfected person, and there's a bottleneck we don't understand. And the bottleneck is such that, generally speaking, the infection event involves no more than 3 viral variants, usually 1 viral variant. So something special about that virus, and so a lot of our work and other groups' work has been to understand why that one virus was successful, because to understand that might lead to new tools for prevention. After the transmission event occurs, so now the HIV has found its way into the mucosa of an uninfected person, but we can see nothing in the bloodstream. We call this, the window. It's a window where we can't find any virus in blood, but we assume it's replicating in tissue. And then a bad thing happens. There's ramp-up viremia. So the highest concentration of virus will transpire in the first few days after HIV infection occurs. That's the most virus the person will ever have, usually millions of copies or hundreds of thousands of millions of copies. Then the host defenses try and constrain the further replication of HIV. And furthermore, each virus kind of knows how much it wants to grow. And different types of viruses grow to different amounts. At the same time as the ramp-up viremia is occurring, the host becomes incurably infected because the virus integrates into cells and creates a pool of latent reservoir, a pool. And lastly, all the compartments in the body are seeded, and particularly important is the central nervous system and the genital tract, because as we are going to try and cure HIV, we're going to have to cure not just the corpus, we're going to have to cure the central nervous system and the genital tract, which are often considered privileged sites. So this is how we understand transmission, and now we're trying to prevent transmission. Of course, most of our energy, and rightly so, has gone into trying to change human behavior to keep uninfected people uninfected. This gets a lot of criticism because it hasn't succeeded sufficiently, but we have no idea what would have happened if we had done nothing. So the number of cases we see now in the face of all we've done to change behavior might be twice as many or 3 times as many. But there's certainly no magic bullet unless it's circumcision, which turns out to be a very powerful intervention to keep men who are HIV negative. So let's focus then on the moment of exposure. What might we do at the moment of exposure? The 2 popular strategies right now are pre-exposure prophylaxis, which represents the topic of a symposium next 2 doors down, and monoclonal antibodies. And I'm going to talk pretty quickly and briefly about each of these things. So the first issue is Truvada. The tenofovir FTC combination was approved in 2012. Pills taken daily clearly have the power to reduce acquisition of HIV. They bathe the tissues in these drugs, and the tissues have a lot more trouble becoming infected. Now, the problem has been, and so we have a biological reality that's been within reason proven, but it's been difficult to get sufficient uptake. Maybe the populations at greatest risk don't really want to take these pills. We're not sure. Furthermore, taking pills is always hard. There's no disease for which daily pills are required that people do great. Hypertension or diabetes, people have trouble taking pills every day. So for that reason, we see investigators worldwide exploring other strategies, and these PROUD study and the Ipergay study, 067, these are all studies trying to argue that if you were using less than daily dosage, things would go better with use of these drugs. And so they're exploring precoital and postcoital and pre- and postcoital and intermittent dosing, hoping that the pharmacology of Truvada is such that it's forgiving in less than daily dosage. Now, one special point. Women and men, if we're dealing with men who have sex with men, we have to be blunt that anal intercourse and the rectum are particular vulnerable sites, and the pharmacology of Truvada in the rectum is quite different than the vagina. So we have to always be considering that intervention might work differently in the MSM population than it might work in the female population. We're open to that possibility. Now, because the pills have been less, it's been difficult to get tremendous traction with the pills. We're still trying, and they play a big role, but already we're exploring alternatives. And one idea that's very popular is an injection that could be used infrequently. And so we see two drugs being pursued aggressively as injectable agents that are nano-suspensions that are leached out of the tissues very slowly that allow you to get an injection every 8 weeks or 12 weeks. One drug is rilpivirine injectable, and that's being tested in HBTN-076, testing 132 women, and that's already 50% enrolled. This is a pharmacology and safety study, as shown on this slide. Another drug that is very popular right now is cabotegravir. It's a potent integrase inhibitor with a very high barrier to resistance. And cabotegravir, when given to animals, has a profound effect. So here's rectal challenge of animals getting cabotegravir. Here's the animals getting infected. Here's the cabotegravir dose, completely protecting the animals. Now, a study has been completed about the safety and pharmacology of cabotegravir. It's called the ECLAIR study, which enrolled 120 subjects, and the data is just now becoming available, and that will inform the use of this product. In this study, we already know that the drug is proven safe, and that's really important because you're injecting something we can't get out into an otherwise healthy subject. So the barrier for safe usage is very, very high. Now, 120 subjects is not a lot, but it's performed very well in safety in that regard, and the pharmacology data is just becoming available, and the NIH has agreed that this data sets the stage to consider a trial of cabotegravir, a phase 3 efficacy trial, and I'll get to that in a minute. But another study of cabotegravir is going on in the Prevention Trials Network, which by disclaimer I helped to run. HBTN-077 is testing 176 men and women versus placebo, again to test safety and pharmacology, and we have no pharmacology data yet from women, and that's quite important because the epicenter of the epidemic is in young women in sub-Saharan Africa. The possibility we might want to use this drug in some of those populations is very high, but we need safety data and pharmacology data to know how often to give this drug, whether we can expect it would work. So all of this leads, and especially the ECLAIR study, leads to a clinical trial that's already being designed by Dr. Rafi Landovitz, who's also running the HBTN-077 study. Dr. Landovitz proposes a phase 2b efficacy trial to prove that an injection of cabotegravir will prevent HIV acquisition, and the first trial will be done in men who have sex with men in the Americas, both North America and in South America, or Latin America. The study design is shown on the slide. It's a double-dummy, double-blind study, and it's got kind of it has three phases, this kind of a study. The first phase, before you give a person these shots, you give them pills of the same drugs. You're giving them the pills to try and prove to yourself it's safe, because if the person gets a rash or an allergic reaction, the pills will be gone in a day. Once you give the shot, it's there for a very long time. For example, low doses of that drug in the blood after a shot may be present for months and months and months. So we would like to avoid allergic reactions. So if the drug proves safe in the run-in phase, then the injections are given every 8 to 12 weeks. We're debating the exact time frame, but right now it might be 12 weeks. The run-in phase is important. And now we have another problem. We have to, because Truvada works, you have to compare, we believe you should compare cabotegravir to Truvada. So you have a placebo injection and a pill that's cabotegravir, a pill that's Truvada, and then you have the active injection and a pill that's a placebo. That's the double-dummy, double-blind design because you're actually making a non-inferiority comparison. And that's pretty typical in this setting, although it leads to a very large sample. And now we have a third problem. So the first problem is the run-in, you got to give some pills. The second problem is comparing to Truvada, which makes the sample size bigger. Now we have a third problem. Now you're going to stop the study, and you've got drug in blood, and the drug is getting lower and lower and lower concentration. That puts this person at risk for acquiring HIV during what's called the tail, which is here. The tail, and if they acquire HIV as the drug is present at a low concentration, inevitably resistance will develop. So a third challenge of this study is covering the tail. So now you've got to give Truvada or something like Truvada during the tail. but you're now dependent on people taking pills to cover the tail. So you can see this is a difficult, complicated study, and yet we believe there's no option but to go forward, because otherwise there's going to be nothing beyond Truvada. So this is a trial that will happen in one way or another in the coming years. So let's shift gears incredibly. So we've talked about injectable agents, and right now there are two. I've told you about a rilpivirine injectable and cabotegravir injectable. Let's go to monoclonal antibodies. So there's two ways people are trying to make a vaccine. One are called non-neutralizing antibodies, and I'm not going to talk about those vaccines. There's a trial that's going to start with a vaccine that might induce a non-neutralizing antibody. But the hottest topic in vaccine development are called neutralizing antibodies. This is the structure of HIV, and these are all vulnerable sites where people have identified antibodies using new technology that can kill multiple strains of HIV. And we're going to focus on antibodies that attack the CD4 binding site, and we're going to look now at different antibodies. These are all different antibodies. Everybody has their own monoclonal antibody harvested from a human who made a broad neutralizing antibody. And here you're looking at the percent of strains inhibited, so more is better. And here you're looking at the concentration, so less is better. The least amount of antibody you need to kill the most strains of virus is the best antibody. And everybody has their own best antibody. But at some point you have to make a decision. And the NIH and the PTN and the VTN, the networks, have decided to focus on VRC01. VRC01 is this antibody that is potent, kills about 80 to 90% of all the strains of HIV across clades, and is potent enough that a concentration that can be achieved through passive immunity might be expected to work. Here's an experiment where you take the monoclonal antibody, you run it into an animal, you challenge the animal in their rectum, and you show that you get perfect protection from the virus in the challenge. So it inspires you to believe that it might be possible to prove or disprove that neutralizing antibodies that kill a lot of strains of HIV provide protection from HIV. This is a big, big, expensive experiment. Why should it be done? Because if you try and move forward with vaccine development without ever doing a passive immunity study, you're working in a black box. If a passive immunity study works, it inspires a generation of scientists to try and make a vaccine that forces neutralizing antibodies. If passive immunity fails, you say, whoa, this really doesn't work, and we're going down the wrong tree. And then the other point is passive immunity in and of itself might be a prevention effort, because you can modify the antibodies so they can last 6 months or longer in the bloodstream. So there's a lot of excitement about these neutralizing antibodies, and Dr. Corey and I are managing a study that's just starting called VTN703 HPTN081. And as you can see, there are 2 doses of the neutralizing antibody that will be given to 2,600 men who have sex with men, and I think it's 1,300 women for 3,900 subjects, and there's a placebo-controlled trial of this infusion. And in order to do this, you need to have somebody sit for an hour and get an infusion, not a shot, an infusion, and all the counseling and other activities that take place, and remain in the study for a very long period of time, requiring us to give a very large number of infusions to prove this works. This study, though, is believed to be, represents a very high priority across the prevention field because of its ability to inform the vaccine field and open up a whole new product line of monoclonal antibodies. So there's tremendous excitement about it, and the first patient will be enrolled, I believe, in November of 2015. 2 doses are being used because we'd like to use the least dose of drug possible. If it works, the lower the dose of drug required, the better. And if it requires a very high dose of drug, it might be beyond what a vaccine could ever do. So let me end then with what is kind of in many ways dearest to my own heart, and that is treatment as prevention. So for many, many years, our group and others have worked on the idea that ART provided to an infected person will render them no longer contagious. In order to test that hypothesis, we developed the study HPTN052, which in 2011 reported interim results showing a very substantial prevention of ART within discordant couples. In the room next door, we had the chance to present the final results of the study, which I will now show you right now. So it's as if you went to the abstract next door. This is exactly what happened next door. Okay, so here's the deal. There are 3 windows of this study. The first window is April 2005 to May 2011. That's what's been reported. There was one transmission event in the early arm, and we know that one transmission event occurred very soon after the subject enrolled in the study, explaining why it occurred. These are people, the early arm are people who are getting ART, and the delayed arm, people are not getting ART, and there were 36 transmission events, and this led to 97% reduction of HIV transmission ascribed to ART when ART is superimposed on condoms and counseling. That involved 3,482 couple years of follow-up. The study was always intended to go for 5 years. So now we're going to go for 5 more years, May 2011, or 4 more years, May 2011 to May 2015. So what happened? During this entire window of time, now adding 5,012 couple years, there's 2 transmission events in the early arm, and I'll tell you right now, those 2 transmission events in people receiving ART were ascribed to either very early transmission right after the drug was started or somebody who had failed their treatment. So all 3 transmission events in the early arm when antivirals were being given had an explanation, like as an intention to treat explanation. Now you see in the delayed arm, you see only 7 transmission events in the delayed arm compared to 36 transmission events. Why is that? Because in 2011, we offered and inspired all the people in the delayed arm to start ART. And so as anticipated, as they started ART, and 98% of them started taking ART, all the transmissions in the delayed arm disappeared, or almost all of them. Why did the 7 occur? Because it took us 2 years to get everyone on the ART they needed. Some of the subjects were resistant to taking ART because our culture of that you don't need treatment was so strong that even in a trial we had to break that culture to get everyone on ART. So that brings us to the final results of the study. There were 46 linked transmissions. There were 78 overall transmissions, but we're concerned about what are called linked transmissions, where we have studied the virus and know that the virus in the bloodstream of one person was transmitted to the partner, the next person. And there were 3 linked transmissions in the early arm, but those 3 transmissions are pretty much explained by the study of the virus itself. There were 43 transmissions in the delayed arm, so this was 93% effective by intention to treat, which is a conservative estimate, and by as treated, it's probably very close to 100% effective, if not 100% effective. So the interim results showed that ART has a big magnitude of prevention. The final result shows durability, that ART can be expected to provide protection as long as the index infected partner takes their pills reliably. On the other hand, if the person stops taking their pills, the partner's not protected. Just being in a partnership for a very long period of time doesn't matter, because once you stop the pills and the virus comes back, risk is reassumed. And that's really quite important. So for couples counseling of both men and women, we're very concerned about developing a formula, strategy of what to tell people. How long after you start your ART are you rendered not contagious? And how do we assure people are taking their medicines to protect their partner? Well, one thing you can see is marrying the first part of my talk and the second part of the talk. What if there's injectable agents where the couple agrees as a couple that the partner, the infected person, is going to take injectable agents for treatment, which is a whole other strategy. And if they don't take their agent, the healthcare provider is given permission to tell the partner, by the way, your partner didn't come to the clinic. This exists within the HIPAA laws in the United States, that couples can agree to be giving each other information. So you can see the future for couples is very rosy, where we think we can create an environment where no partner would ever become infected because we could use these long-acting injectable agents, which I think is a possibility. For 052, the conclusions were that the benefits of early ART are durable. We saw no linked infections when viral suppression occurred, and we conclude that ART is a very highly reliable intervention to prevent the transmission of HIV, the sexual transmission of HIV.